All right, we'll go ahead and get started. So hello everyone, and thanks for joining highlights from the 2022 CPT code set update. My name is Jordan Leibovitz, and I'm part of the marketing team here at IMO. Before we get started, I want to take care of a few items for those attending. This webinar is being recorded and will be available to you for future viewing. Throughout the session, all attendees will be in listen-only mode. So if you have any questions, please feel free to type them into the question section on your GoToWebinar console. At the end of the presentation, we'll have a Q&A session as well, and we'll get to as many questions as we can, but for any reason, yours that's not addressed, we will follow up with you after the webinar. We like to keep things interactive, so throughout the presentation, we'll be launching poll questions. Today, we have two presenters from IMO, our Senior Director of Global Clinical Services, June Bronnert, and our Mapping Manager, Shelley Jude. As mentioned before, if you have any questions or comments while our presenters are speaking, please type them into the questions section on your control panel. And with all of this being said, I'll pass it over to June.
Thank you, Jordan, and welcome everyone. Let me begin with a little background about IMO. IMO has been the primary driver behind clinical interface terminology. We began in 1994 when few clinicians were even using electronic health records. Today, we are the premier supplier of clinical interface terminology to the United States and English-speaking market, with more than 70% of acute care facilities, 4,500 hospitals, and over 500,000 daily clinician users in the United States alone. We know for many of your organizations, COVID-19 continues to present challenges, which may have caused significant financial strain. Any disruption in the revenue cycle is highly impactful, and prevention of submitting outdated or wrong codes resulting in denied or delayed reimbursement is key. Ensuring your organization is ready for the new CPT codes effective January 1st supports an uninterrupted revenue cycle. So let's get started looking at CPT changes for 2022. Here's what we plan to achieve today. As you can see, identify the new guidelines and code changes throughout the various surgical sections, review COVID-19 pathology, lab, and vaccination codes, as well as explain fracture dislocation, restorative guideline changes, and review changes to the evaluation and management section guidelines. So let's start with changes by the numbers. There's a total of 405 changes overall, with 249 added codes, while 63 codes were deleted and 93 revised. And in addition to the code changes, there were multiple guideline revisions and additions. We won't be able to go over all the updates in this time, but we have selected the most relevant areas to share with all of you. And we'll start with the musculoskeletal. One of the biggest changes for this area is the changes related to restorative care guidelines. The change provides additional guidance to determine the appropriate code when various services are provided to stabilize and/or repair a fracture or dislocation. Please refer to this guidance when reporting fracture or dislocation treatment codes. It's a common clinical scenario for patients to seek medical care in an emergency department following an injury such as a fracture and subsequently see an orthopedic provider to continue the care and treatment of their injury. The changes clarify this scenario along with cast, splint, and traction services. So let's start by looking at the types of treatment. The types of treatment approaches CPT defines are open, closed, and percutaneous. Manipulation and fixation may or may not be included with the treatment approach. For example, internal fixation devices may or may not be placed during an open treatment approach of a fracture. Let's look closer at the treatment approaches. Open is defined as the site is open surgically to expose the fracture or dislocation to the external environment for treatment, or the injury is treated through the traumatic wound, or treatment is with an intramedullary nail or other internal fixation device placed through a surgical exposure that is remote from the fracture site with or without direct visualization of the fracture site. Close is defined as not being surgically opened. Closed treatments may or may not include manipulation, which we will discuss further in a bit. Percutaneous is defined as treatment that is neither open or closed. fracture fragments are not visualized, but fixation is placed typically using imaging guidance. Fixation and immobilization are types of stabilization. Fixation devices are further refined by whether they are placed internally or externally. Examples of internal fixation devices are shown here on the screen, such as pins and screws. Procedure documentation such as open reduction internal fixation, or ORIF, is commonly seen when placing these devices. So the ORIF is an example of open treatment with the internal fixation device placement. External fixation devices may be used as temporary or long-term stabilization and may be placed via any treatment approach. The device is commonly used in children and keeps the fracture aligned throughout the healing process due to external adjustments. The codes are reported separately when placement is not inherent to the procedure, as noted in the code description. External fixation devices involve the use of any of the following: pins or wires, such as Steinmann pins or K-wires, and/or interconnection pieces, such as clamps and external fixation rods. The pins or wires penetrate the bone, while clamps, bars, or rings connect the elements of the device for stabilization. There are three basic types of external fixator devices, which are either uniplanar or multiplanar. The types are standard uniplanar pin fixator, ring fixator, and hybrid fixator. Standard pin fixators are commonly used for complex distal radius fractures, while ring fixators are more common for proximal or distal tibial fractures. And hybrid fixators use a mix of ring and standard pin fixation and may be used for tibial fractures that are close to the joint. The CPT book provides images of external fixation devices in greater detail on the various devices. It is important to note that there is no coding connection between the type of fracture or dislocation and the type of treatment. For example, a closed fracture may have an open treatment with or without internal fixation device placement. Now let's look closer at the definition of manipulation and its connection with closed treatment. Manipulation is the satisfactory alignment of a fracture or dislocation via manually applied force. A closed treatment approach may or may not include manipulation. There is one body site that Shelley will discuss later where CPT guidance varies when there is closed treatment without manipulation. Closed treatment may also include skeletal or skin traction. Please refer to the updated guidelines for further definition of skeletal and skin traction. A key guideline revision is casting, splinting, or strapping that is used solely to temporarily stabilize the fracture for patient comfort is not considered closed treatment. And next we will look at the revisions to the cast, splints, and/or strapping guidance. The guidance is located at the beginning of the musculoskeletal section or chapter, along with the application of cast and strapping subsection. This guidance clarifies when it is appropriate to report the application and/or removal of the cast and straps. As noted here, the first application and removal are typically included with the services provided in musculoskeletal section. The new guidance indicates the clinical scenarios for when it's appropriate to report the separate service. Now it's time for our first polling question. What is the appropriate code for a patient with a displaced radial fracture that is manually reduced and a cast applied? A, 25600, closed treatment of distal radial fracture without manipulation, and code 29125, application short arm splint. B, 25605, closed treatment of distal radial fracture with manipulation. C, 25607, open treatment of distal radial fracture with internal fixation. D, 25606, percutaneous skeletal fixation of distal radial fracture, and code 29125, application of the short arm splint. Jordan, can you please launch the poll?
Okay, June, it looks like there's a pretty even tie between B and D.
B and D. Well, the correct answer is B, 25605. The manual reduction is manipulation. The approach is closed as there was no mention of an incision or exposure of fracture site, and the cast application is integral to the closed treatment in this instance. So we'll continue on with category 3 codes for musculoskeletal. As you can see, there are new codes here. The extracorporeal shock wave therapy codes for the musculoskeletal system, lateral humeral epicondyle, and integumentary wound healing were revised to delete the terms high or low in regards to energy from their description, as this energy distinction is no longer current practice. Note the code 0102T is specific to the lateral humeral epicondylitis, or more commonly known as tennis elbow. For other tendinitis conditions, the code 010T is appropriate to report as it refers to musculoskeletal system in general. For the code 0707T, the injection includes both the image guidance and the arthroscopic assistance. Please refer to the parenthetical notes for additional details. Next, we will review changes to the spinal arthrodesis. Starting this year, the guidelines for spinal arthrodesis now include definitions. The definitions shown here outline the various areas of the spine that may be removed. The book includes an additional definition for the body side of the lamina. The lamina is defined as the flattened posterior portion of the vertebral arch. In addition to the definitions that were added, the book contains various vertebral body images with text indicating the various anatomical sites and procedures. The definitions are important for clarification and supports the distinction for the 2 new codes we will review on the next slide. The 2 new codes, 63052 and 63053, were created to support the separate reporting of decompression from the fusion when appropriate. Note, a decompression performed solely to prepare the inner space for a fusion is not separately coded. Code descriptors were also revised for consistent use of terminology related to inner space versus level when describing spinal procedures. For example, code 22614 now states each additional inner space instead of each additional vertebral segment. Turning our attention to neurosurgery, we will review 3 areas of change, starting with the laser interstitial thermal therapy, or LITT. The intracranial laser interstitial thermal therapy is used to treat various brain tumors or focal or drug-resistant epilepsy. LITT is performed by using MRI guidance for implanting a laser catheter into the tumor or the source of the seizure area. Once the laser is in place, the provider heats it to temperatures high enough to kill the tumor or the designated area. The surgeon then removes the catheter's wires and closes the incision. The 2 new codes for LITT, 61736 and 61737, are differentiated either by the number or the complexity of the areas or tumors being destroyed. Destruction of interosseous basivertebral nerve also has 2 new procedure codes for 2022. The codes are 64628 and 64629. The distinction between the 2 codes are noted on the slide. This procedure is formed by making an incision and placing an introducer trocar into the transpedicular approach to the posterior vertebral body to identify the basivertebral nerve. Once the nerve is identified, a bipolar probe delivers radio frequency for 15 minutes in order to destroy the nerve endings. The process is repeated at other levels as necessary. The last area we will review is anterior vertebral body tethering. Codes 0656T and 0657T were created to report anterior body tethering. This procedure is used to treat idiopathic scoliosis, which requires surgical intervention. The procedure does not involve a spinal fusion or arthrodesis and does not interfere with growth and/or mobility. The procedure typically involves the use of video-assisted thoracoscopic surgery or VATS techniques to access the anterior thoracic spine. Next, the vertebral bodies are exposed to place the anchor screws and a tension cord. Compression and tightening of the set screws occurs and the surgical site is closed. See the parenthetical notes for the codes to not report together with these new codes. Now let's look at the cardiovascular changes. Left atrial appendage or LAA procedure is used to treat atrial fibrillation and mitigate postoperative thromboembolic complications. Exclusion of the left appendage occurs via excision, stapling isolation, oversewing, ligation, plication, or clip. This procedure may be performed in conjunction with other procedures requiring a sternotomy or a thoracotomy approach. So for the open approach codes, the code 33267 may only be reported when there is no concurrently performed procedure that requires a sternotomy or a thoracotomy approach. The add-on code 33268 may be reported concurrently with a primary procedure performed via sternotomy or a thoracotomy. LAA is inherent to maze or mitral valve repair replacement procedure, so a separate code is not reported when performed at the same time. Now looking at the cerebral embolic protection devices, one of the surgical risks of various interventional cardiovascular procedures is embolic debris fragments becoming dislodged and traveling to other intravascular locations and causing adverse events such as a cerebral vascular ischemia. Embolic protection devices are being placed to help reduce these adverse events. Cerebral embolic protection devices are filters designed to capture or deflect the embolic debris fragments from traveling to the brain. The filters are typically placed in the brachiocephalic artery and the left common carotid artery and are removed at the end of the procedure. 33370 is a new add-on code and may be reported for the cerebral embolic protection in conjunction with transcatheter aortic valve replacement or an aortic implant. The code includes access, placement of the guiding catheter, along with the delivery and placement of the embolic protection filters. The code also includes removal of the filters along with any debris and removal of the arterial sheath and wound closure. Extensive repair or replacement of an artery may be additionally reported. In addition, the code 33370 includes all imaging guidance and radiological supervision and interpretation that are associated with performing the cerebral embolic protection. Aortic cortication is when there is a narrowing of the vessels around the aorta. A new subsection titled Endovascular Repair of Congenital Heart and Vascular Defects was added with introductory guidelines in order to report these endovascular procedures. The new codes identify when the repair involves a stent placement or no stent placement. If a stent placement occurs, the codes distinguish when the repair is across or not across major site branches. Code 33894 is for services across the major side branches, while 33895 is not crossing major side branches. There's a new subsection guidelines and codes that are added for cardiac catheterizations for congenital heart defects. The new subsection reflects advances in treatment, and with the addition of 6 new codes, 5 of these codes reflect the various heart catheterizations and 1 new add-on code. The new heart catheterization codes identify if the patient has normal or abnormal native connections as shown on the screen. Normal native connections are when the blood flows along the expected course through the right and left heart chambers as well as the great vessels. Abnormal native connections is the opposite, as the blood flow pathway occurs via alternative connections. And as you can imagine, abnormal native connections typically occur in patients with abnormal cardiac anatomy. such as hypoplastic left or right heart. Code 93598 was added to report cardiac output measurements used during a cardiac catheterization for congenital heart defects. Guidelines and parenthetical notes have been added or revised across many sections, as in the surgery, radiology, and medicine, to reflect these new codes. This slide is a reference of reflecting normal and abnormal native connections, along with samples of potential diagnostic conditions associated with each connection. Other cardiovascular changes are related to vessels harvesting for the CABG or coronary artery bypass graft procedures. 33509 is a new code for endoscopic arterial harvest, while endoscopic venous harvest is reported with 33508. Code 35600 has been revised and now references if the harvest is an endoscopic approach, as well as the other revision to this code is it is no longer considered an add-on CPT code. The instructional notes for subsections combined arterial venous grafting for coronary artery bypass and arterial grafting for coronary artery bypass have been revised to identify both the open and endoscopic method of the arterial harvest, which is separately reportable. Next, let's look at cardiovascular imaging. An add-on code 93319 identifying 3D cardio imaging is new for 22. 3D echocardiogram provides visualization of cardiac valves and congenital abnormalities and should typically be used in conjunction with a transesophageal cardiography or TEE. 93303, 93304 are the transthoracic echocardiograph codes for congenital heart defects. This is a new add-on code and is appropriate to report with these codes. The 93312, 314, 315, and 317 is for both standard and congenital transesophageal echocardiography codes. Again, this is an add-on code. It's appropriate to report with these codes, the 93319. And of note, 93312 code represents a TEE, while code 93315 is the congenital TEE. Do not use this code when the transthoracic echocardiography is performed as guidance for other transcatheter intracardiac interventions, such as a mitral valve repair. Next, we will review cardiac ablation revisions. Cardiac ablation surgery is used to treat various arrhythmias, and the procedure destroys tissues in order to return the heart to normal rhythm. An ablation is typically performed using multiple catheters to map out the pathway and reproduce the arrhythmia in order to identify the area to ablate. The codes 93653, 93654, and 93656 represent a comprehensive electrophysiological evaluation, or an EPS, with ablation. This year's revisions clarify which services are bundled with the 3 procedure codes shown here, while also identifying which components are integral to the procedure represented by these codes. For codes 93653 and 93654, the 3D mapping and left atrial pacing codes shown on the screen are bundled services and not separately reportable. The code 93462 is separately reportable for the SVT and VT ablation codes. And atrial fibrillation ablation also bundles the 3D mapping 93613, but considers codes 93462 and 93622 as integral components of the code 93656. A table has been created for the 3 comprehensive EPS with ablation codes for reference. And on the next slide, we will review a few of the elements of this table. The new table is created for 2022, and it does identify by code the various components of a cardiac ablation procedure and which components are integral to the overall ablation. Not bundled or unbundled is for procedures that are not routinely performed with the ablation but could be performed. Refer to this new table in your CPT Codebook 2022 for further details. Intracardiac echocardiogram, there are several cardiac catheterizations and the electrophysiological procedures have been added since this code was activated. So the revisions clean up which code this is an add-on code for to report to use with another base CPT code. For example, 3 add-on codes as shown on the screen were removed as appropriate to add with 93662. In addition, the new congenital heart catheterization codes were added to the list of use in conjunction with, so this code is appropriate to assign in addition to one of the new congenital heart cardiac catheterization codes. The cardiac rhythm monitoring devices are used to record a patient's cardiac rhythms in order to diagnose suspected arrhythmias. The devices are automatically activated by rhythm changes or by the patient if they are having a symptomatic episode. The devices are placed subcutaneously. The new technology allows for providers to program these devices remotely, and current codes for programming the devices are for in-person sessions. So this new code identifies a remote session. Programming the device regardless of in-person or remote includes device interrogation, the evaluation testing, as this is integral to the programming services. When reporting this Category 3 code, review the guidance note prior to the code, as well as the parenthetical notes by the code to determine which codes are appropriate or not to report in addition to this Category 3 code. Other Category 3 changes for this coming year are shown here. Non-invasive arterial plaque quantification procedure analyzes both the structure of the plaque within the vessel along with compositional biomarkers or indicators of atherosclerosis. Examples of biomarkers are C-reactive protein, cytokines, or oxidized LDL. Body surface mapping is performed to optimize the electrical signals by locating the optimal placement for the device. The codes are used in conjunction with other services such as pacemaker insertion, replacement evaluation, or programming. See the parenthetical notes for the specific additional codes that may be reported with the body surface mapping codes. Implantable synchronized diaphragmatic stimulation system is used to augment cardiac function. The system may be recommended for patients diagnosed with heart failure as it is designed to decrease the heart's effort to pump blood throughout the body. The system consists of a pulse generator and 2 diaphragmatic leads. The generator is placed subcutaneously like pacemaker generators, but instead of the chest wall, it is placed in an abdominal pocket. The electrode leads are placed on the inferior surface of the diaphragm. The system is designed to induce contractions of the diaphragm muscle involved with the cardiac cycle. The goal is to augment the intrathoracic pressures and therefore improve the left ventricular function and ultimately the cardiac output. Code 0674T is for a complete system regardless if the system is new or a replacement system to the patient. This code includes the pulse generator and any lead or leads. For individual components, there are unique codes to represent these services. As you can see here on the screen, 0680T to 0682 represent work on only the pulse generator, whether it's insertion, replacement, relocation, or removal. On the next slide, we will look at the leads. 0675T to 0678T represent the insertion, reposition, or removal of the leads. Note for the insertion and reposition lead-only services, the codes reflect an initial lead and then each additional lead. The new Category 3 codes also include programming and interrogation services. The non-peri-procedural programming services are typically included with the insertion codes unless the service is performed at a different date or by a different provider. Lastly, there is a code 0685T to identify when the service is only interrogation and no programming occurs. Other Category 3 changes include the introductory guidelines were added for these codes. Code 0643T describes a transcatheter left ventricular restoration or an LVR device implantation using an arterial approach. The approach is performed to treat conditions such as left ventricular failure and congestive heart failure. Code 0644T describes percutaneous transcatheter removal or debulking of an intracardiac mass via suction devices. Code 0645T describes a new transcatheter procedure in which the valve prosthesis is implanted in the coronary sinus and therefore creating a permanent narrowing of the coronary sinus. Code 0646T describes a new transcatheter procedure also in which a valve prosthesis is implanted or an existing prosthesis is replaced within the tricuspid valve. Code 0659T was established for a new therapy to report transcatheter intracoronary infusion of a supersaturated oxygen during an acute myocardial infarction. And therapeutic ultrafiltration is a process by which blood is filtered through a semi-permeable membrane to remove isotonic plasma water and to restore the patient's volume status. A new Category 3 code is added for this procedure. Now let's turn our attention to vaccination changes. This slide is a reminder that vaccinations require a minimum of 2 codes. One code is for the product itself, and the second is for the administration of the vaccination. Examples of vaccination product is on the left, and the administration examples are on the right. COVID-19 vaccinations have a unique template, which was established for 2021. Here is a reminder of the code pattern for the SARS-CoV-2 vaccine codes. There are 8 new codes to represent the various products from the manufacturer as seen on the slide, and 20 new administration codes for the injection itself. The COVID-19 administration codes reflect the different doses. CPT has added a new appendix. This is Appendix Q, Severe Acute Respiratory Syndrome Coronavirus 2 Vaccines. Please refer to the AMA's website for the most up-to-date on the information regarding the codes for COVID-19 vaccinations. Here are examples of different manufacturers, the product code, along with the administration. As you can see, the various examples of 91307 for the code product and 0071A or 0072A is just one example. And again, please refer to the AMA's website for the most up-to-date information around these codes. We will review the non-COVID-19 vaccination additions on the next slide. These are new codes to represent the vaccine products shown here. And there are 2 codes for tick-borne encephalitis and pneumococcal conjugate. The Ebola and hepatitis B3 antigen also have new codes. As previously stated, the administration codes are also reported at the time of the vaccination. And now I would like to turn the presentation over to Shelley to review other changes.
Thank you, June. I'm going to start with pathology and lab changes. The high-level changes on the lab and pathology on this slide are 81 changes across pathology section, 69 PLA changes, and COVID-19 testing codes have been added to the book. Some laboratory changes that have occurred mostly in the therapeutic drug assays. There is a new code for hydroxychloroquine. If you have listened to the news over the past year and a half, you have heard of this drug name being referenced in relation to COVID-19 treatment. Remember, a therapeutic drug assay determines how much of that drug is in the patient's system after they have taken it. So if the patient took a dose of it, how is the body metabolizing that drug? You can find this out by doing this test. New codes for celiac disease have been added as well. Remember, this is an autoimmune disease, so these tests are testing for some of those immunoglobulin and antibodies present to determine this disease. Next are laboratory COVID-19 testing. These are new codes to the book, but most of them have been effective since 2020. Accepted edition of code 87428 for reporting multiplex viral pathogen panel using antigen immunoassay technique for SARS-CoV-2 testing along with influenza A and B. On August 10, 2020, the accepted edition of codes 86408 for reporting coronavirus 2, neutralizing antibody screen, and 86409 for reporting coronavirus 2, neutralizing antibody. In addition, one code 86413 was created for reporting quantitative antibody detection of severe acute respiratory syndrome coronavirus 2. Again, we do encourage you to monitor and closely pay attention to the AMA website for additional codes listed. Some additional codes that will be added for COVID-19 testing continued are 87811 and 87636 and 87637. The accepted edition of 87636 for reporting combined respiratory virus multiplex testing with either the SARS-CoV-2 along with that influenza A and B, and code 87637 for combined respiratory virus multiplex testing for either SARS and that influenza A and B and the RSV. And the 87811 for antigen detection of SARS-CoV-2 by direct optical visual observation. And that visible observation language has been added to most of the language for these tests. For pathology, clinical consultations have been added new codes, and these new codes are not face-to-face visits between the patient and the pathologist. The pathologist instead is reviewing the patient's records or maybe some slides, but they are giving their opinion on that patient condition. They are diagnosing, but they are diagnosing related to those office visit changes and the changes in medical decision making. They have made changes to the tables on pages 614 through 615 in the 2022 CPT professional manual. These can be codes by medical decision making or by time, and make sure you review these changes in the table. Next, we're moving to radiology. There's a new code for tubercular bone score. This is a separate test that is done after the patient has had the DEXA scan or other type of imaging, and that data is transmitted through this processing software, and then we are able to give a fracture risk score based on what the test data shows. Next, we have radiology category 3 codes. 0673T for percutaneous ablation of benign thyroid nodule, 0647T for percutaneous insertion of gastrostomy tube, but what makes this code unique is with magnetic gastropexy, which the magnet holds that tube in place. 0686T for histotripsy, might sound familiar from another name you know, lithotripsy. Remember, litho is the kidney stone and tripsy is the use of sound waves to break up that stone. In this case, we are doing histotripsy, where we use sound waves to break up malignant liver tissue. 0691T for an analysis of an existing CT scan from some other reason, but we are going to analyze that for vertebral fractures. Additional category 3 codes continued. These involve imaging. Most of our imaging, CT or X-rays, we can see the size and shape of an organ or structure, but we really can't tell the density or the texture or other characterizations. These codes here allow us to do a little more tissue characterization. So not just size and shape, but more details of that tissue. Additional category 3 codes in radiology, 0694T is 3-dimensional volumetric imaging and reconstruction of breast tissue. The patient has had breast biopsy done, and we want to analyze it to see if we got the whole thing. Because remember, we are going in through looking at the mammogram. We have seen it on ultrasound, and the surgeon is going in and having to remove it by sight. They can't differentiate, did they get all of it? So this is done intraoperatively, real time, while the patient is on the table. We are going to analyze that specimen and compare it to what we saw on the imaging to say we got it all. For 0700T and 0701T, these are codes currently in radiology section of the CPT manual, but may end up in dermatology because these are to analyze a lesion the patient has. So right now you have a skin lesion, you go to the doctor, they cut it and send it out to pathology. The patient ends up with stitches, which increases the risk for infection. This would allow for you to add fluorescent dye to the lesion and take a handheld device to analyze the lesion and determine what it is and how, if it needs to actually be removed. This cutting down the additional trips back to the dermatologist and the risk for infection with stitches. Additional category 3 codes in radiology. You have some additional codes, whether it is MR for organ or multiple organs. Language in the code descriptor specifies that analysis of the tissue composition may include fat, iron, or water content. The code descriptor also specifies that when performing the service, the same anatomy may include organ, gland, tissue, or target structure. Now moving on to urology and gynecology. Category 3 codes 0548T through 0551T have been converted to Category 1 codes 53451 and 53454. These codes are for patients with incontinence, and these are procedures where we are going to treat with inserting a balloon device. And we have codes for adjusting, insertion, removal, and percutaneous adjustment of fluid volume of the balloon. Codes 53451 through 53454 have been established to report periurethral transperineal balloon continence device procedures. To assist in appropriately reporting if this new family of codes, there are several exclusionary parenthetical notes that have been added throughout the code family, and deletion of parenthetical notes have been added to the Category 3 section. Instructional parenthetical notes have been added in Category 3 section to direct users to report codes 53451 and 53454. Next, we have a new code 11981. It describes the insertion of drug delivery implants such as resorbable, biodegradable, or non-biodegradable implants. A parenthetical note has been added following code 11981 to instruct users to report unlisted code 17999 for removal of a biodegradable or bioresorbable implant. Next are Category 3 codes. This is a new procedure introduced at the CPT Symposium and is exciting to hear is going to be being performed. Some examples offered were a patient born without a uterus or a patient who had their uterus surgically removed. And most of these procedures have been done with a cadaver donor uterus, although we do have codes for the living donor. The procedure is being performed on those patients who want to have a live birth and do not have a uterus. I am excited for this technology, and it is being performed. Dual energy tissue remodeling 0672T treats urinary incontinence by remodeling the tissue surrounding the female bladder and proximal urethra. Additional Category 3 codes in this section, 0655T, has been established to report transperineal focal laser ablation of malignant prostate tissue. This procedure is designed to treat conditions such as prostate cancer. Prior to 2022, ultrasound-guided or ultrasound fusion-guided focal laser ablation of malignant prostate tissue was not described in CPT code set. An exclusionary parenthetical note following code 0655T has been included to guide users to appropriately report these procedures with other procedures in the CPT code set. Now moving on to the digestive system. New codes, one is for drug-induced sleep endoscopy. This is like a laryngoscopy, but the distinction here is we aren't going diagnostic looking for a lesion. We are going to watch the patient's throat, tongue, and larynx when they sleep to identify the problem. What is causing the patient's sleep apnea, and what do we need to do to treat? So basically, we are monitoring patients' throat as they sleep in code 42975. For code 43497, the lower esophageal myotomy is the lower portion of the patient's esophagus is not functioning like it should and moving the food down to the stomach. One of the treatments for that is make an incision into the muscle wall there. There are codes to do this laparoscopically, but now we are going to do it through the mouth orally, and this is known as the POEM procedure. Moving into ophthalmology, the biggest change, especially for retinal specialists, is the change in the wording of the code description that is going to result in a tremendous change in reimbursement. The code for prophylactic retinal detachment, the code number is not changing, but previously the code description stated one or more sessions, meaning it didn't matter how many sessions you treated the patient. You used to have to do multiple sessions to treat the retinal detachment, but now with technology changes so much around this that it can be done in one session and not multiple. They are removing that terminology, but the results in that are that the Medicare reimbursement is decreasing. Medicare said we are paying you more for multiple sessions, and now that is only the one session, we are decreasing reimbursement reflecting that change. In addition, drug-eluting implant. This will be an implant inserted into the tear duct, and it can be done for multiple reasons. For steroids after a procedure, it can be used for treatment of glaucoma. The plug from the implant may fall out on its own, or disintegrate, or on its own, or surgically removed if needed. Additional eye codes. There are two new codes that are basically for cataracts, but with a little more information to it. Patients would come in for cataract surgery and would have glaucoma, and these were being performed separately. Now, while doing the cataract surgery, we are going to insert a device to drain the glaucoma. Remember that glaucoma is fluid around the eye that increases the pressure of the eye that could ultimately result in blindness. The treatment is to make some way for that fluid to drain. This device can be inserted at the time of cataract surgery, so code 66989 is really the basic of 66982 cataract code, but at the same time, you put in the device to drain for glaucoma. And then 66991 is really your basic 66984 for cataract code, but at the same time, you put in the device to drain for that glaucoma. Why did they do it this way? Why not just give us a separate code for the drain insertion? In this case, it is because the aqueous drainage device is not FDA approved unless it is done in combination with the cataract surgery, so that is why they made the combination codes. Additional category 3 codes, 0660T, implantation of anterior segment. The 0661T is the removal, and then 0671 is insertion, and 0699 is the injection. These new codes are another aqueous drainage device and injection medication that does go in the chamber of the eye. Additionally, we have one more section of category 3 codes in the eye, and these have to do with amblyopia of the eye, which is what we use to call lazy eye. These used to be treated by putting a patch over the good eye, but now they have this video game for children, most likely to have this disorder, where they play online and are able to be monitored to see how is this tracking device working on that eye. You have a code for setup, surveillance, and interpretation. Moving on to ENT. Nasal fracture revised codes. Codes for treatment of nasal bone fractures are revised to specify with manipulation and with or without stabilization. Treatment of nasal bone fracture without manipulation is coded with the appropriate E&M. This is an exception to the changes in fracture care. Ear osseointegrated implants, new codes that are mostly commonly known as cochlear implants that you would see behind a patient ear. The device would be behind the ear on the side of their head, and typically this was connected by screws through the patient's skull. They would have the speech processor on the outside and the sensor on the inside connected by a string. This technology allows for the connection to be done magnetically. It is good when you don't have to put screws through a patient's skull. Now the speech processor is magnetically attached to the device. Moving on to digital medicine. There are 5 new codes for therapeutic remote monitoring. These codes are intended to report remote monitoring of non-physiological parameters. They have been created to be analogs to remote physiological monitoring codes, 99453, 99454, 99457, and 99458. However, the main difference between these families of codes is the parameters that are being reviewed. These new therapeutic monitoring codes are intended to monitor services, for example, musculoskeletal system status, respiratory system status, therapy adherence, and therapy response. 98975 is initial setup and patient education on use of equipment, and 98976 and 98977 are intended to report 30-day device supply with scheduled recordings or program alert to monitor the respiratory system and musculoskeletal system. 98980 and add-on code 98981 are intended to be reported per month for the same time spent on remote therapeutic monitoring treatment management services by the physician or other qualified healthcare professional. Appendices additions and revisions. Appendix P, there are codes that can be done via telehealth visit. Appendix R is new this year and lists all the procedures that can be done through digital medicine. It has a nice table that shows who does it and what are the requirements. So I encourage you to review both of these prior to the start of 1/1/2022. Now we'd like to do a poll question. In surgery guidelines, if an implant is no longer useful, causing trouble, it becomes a foreign body for coding. True, false, or you don't know. Jordan, would you please launch the poll?
All right, Shelley, it looks like most people are saying true.
And they are correct. New for 2022, the surgery guidelines include detailed description of what is a foreign body versus an implant. In addition, they provided additional guidance of when an implant will qualify for a foreign body. Now continuing on to evaluation and management. First of all, for evaluation and management, we had a guideline revision. Most of you are aware of the huge changes we had last year in this section, and 99211 didn't have a change. However, in 2022, usually the presenting problems are minimal, has been removed. They are trying to get away from terminology, and they are trying to get rid of this terminology and use a different type of verbiage. So 90785 is not an E&M code, but they did want to clarify that it's used for psychotherapy. It's an add-on code for interactive complexity. It is a visit that we are coding by time that something is going on in that visit to make it more complex, but people were trying to use it on an E&M code, and you cannot. It is an add-on code only for psychotherapy interactive complexity, and the use of a translator does not support the use of this code. Also, they clarified that the use, I already said that, sorry. Additional principal care management. Some big changes we had were in principal care management. Hopefully you are aware, several years ago, we got codes for what was known as chronic care management, and we are recognizing sometimes patients with chronic conditions, they really need some management outside of face-to-face visit. We have these codes for phone calls. Those are interactions where you are not face-to-face, but doing management of that patient's chronic needs, we didn't have appropriate coverage. Chronic care management requires 2 or more chronic conditions, and there are some other parameters there. But if you are only trying to manage one chronic condition, we didn't have a code to capture that work. So we have these brand new codes that were G codes, G2064 and G2065, comprehensive care management, that are not to be used with these new codes. The new CPT codes this year that can cover the management of one high-risk disease. They came up with these codes thinking that a patient that has been in the hospital for an exacerbated disease that is discharged requires a lot more management for outside care that could take up to 3 months. 3 months is not required for the use of these codes, but is the maximum that they can be reported. Here are the codes based on time, and they state by personally being performed or directed by physician or other qualified healthcare professional. And as a reminder, CPT defines that as the qualified healthcare professional as someone who is allowed to do this service by virtue of their education and their state licensure, and they can bill for that service. These codes are mutually exclusive, same calendar month, restriction on use of same time for more than one service, and I would encourage you all to refer to the parenthetical notes after each code for additional guidance. There are additional codes and guidelines around chronic care management and principal care management. A new add-on code for CPT code 99091 for chronic care management, along with new guidelines and tables in the CPT 2022 professional pages 62 through 69, stating that care plan must be updated at least annually. This was not called out specifically. More than one physician can perform and bill primary care management, but only one physician can perform and bill for chronic care management. The thought here was that for chronic care would only be one focused in the chronic condition only. For clinical staff codes, physician time may be added as long as the same time is not used to support any other codes. One of the things that CPT has done a lot of this year is they have added more diagrams, explanations, and tables to aid in selecting the most appropriate code. If you are using an encoder, EHR, or cheat sheet, we highly encourage you to look over the CPT manual for these additions, or you may miss out on these tools being offered. IMO reviews these in depth and apply to CPT codes we assign to our procedures. There are continued struggles with 2021 office visit changes. We encourage you to review AMA technical corrections released on March 9, 2021 to help apply the guidelines. For one example, reporting of test independent interpretation and order reviewed. There were a lot of questions that stated, can point of care tests that are results only, such as dipstick UA, quick strep, and CBC, be counted as ordered or reviewed for selecting a medical decision-making level if the CPT code is billed for those tests? The answer, yes, these simple tests that do not require separate interpretation can now be counted as order review as part of data in medical decision-making, even if the test was reported by the physician qualified healthcare professional performing the office E&M. In addition, use the resources available on the AMA website for additional guidance in these areas. Lastly, I just want to share some upcoming changes for 2023 in the evaluation and management section. These include observation codes will be deleted, inpatient guidelines will change, consultation codes will remain except 99241, and then 99251 guidelines will change. Emergency department guidelines will change, domiciliary code will be deleted, home visit guidelines will change, and annual nursing facility visits will be deleted. Now back to you, Jordan, to start our Q&A.
All right, so thank you, Shelly and June. I know we are at 1 p.m., so we're going to just take a few minutes for Q&A. So if you have any questions, just type them into the questions section. If you need to leave, don't worry, we'll send you the recording and slides along with a certificate of attendance afterwards. So take it away, ladies.
Hi, this is June, and we received a question around guideline documentation requirements for a TAR procedure and what is the minimum. I would refer you to, in this instance, to review from a CPT coding reporting perspective, to review if there's any guidance within the book regarding what is necessary for the TARV code, as well as the professional societies, to see for that documentation. The documentation should reflect the procedure that was performed, and then if there's guidance within the CPT book for that code on what is required to report that. And it seems like there's an additional question or questions related to the continuing ed or offerings. And again, we are able to provide a certificate of attendance, but we would recommend you check with your individual professional organizations for the amount of continuing education that would be granted through each organization.
All right, so it looks like questions are winding down. So we're going to go ahead and close out for today. I hope you found everything valuable in this presentation. Be on the lookout for the recording, and like I mentioned before, the certificate of attendance. If you have any information regarding IMO or any of our solutions, please contact your IMO client executive. And thanks for attending, and I hope you stay healthy and safe out there as we approach the holiday season. Bye.